Welcome to the workshop CAR T-cell therapy for patients with lymphoma. Who benefits? My name is Michaela O'Brien, and I will be your moderator for this workshop. Before we begin, I'd like to thank Kite, a Gilead company, and Bristol-Myers Squibb, whose support helped make this workshop possible. It's my pleasure to introduce today's speaker, Dr. Jay Spiegel. Dr. Spiegel is an assistant professor at the Miami Miller School of Medicine and a hematologist in the Transplant and Cellular Therapy Division of the University of Miami Sylvester Comprehensive Cancer Center in Miami, Florida. He is a translational researcher working to improve CAR T outcomes for B-cell malignancies such as lymphoma. He led first-in-human clinical trials of novel CAR T-cell therapies and investigator-initiated trials testing CAR T in combination with targeted therapies. Please join me in welcoming Dr. Spiegel.
Thank you for that kind introduction. I'm very happy to talk today about CAR T-cell therapy for patients with lymphoma and who benefits. So I first, just a little bit about the agenda. We'll first start with an introduction to lymphoma. I like to take kind of a 30,000-foot view and then hone in, and then we'll talk about some of the science of CAR T-cell therapy and then the CAR journey, both logistical and then the patient experience. So this is a graphic of how your blood system is made, and I think it's most relevant to patients when they're getting a complete blood count. So what are really the main things we look at when patients get a CBC? First, the red blood cells, they provide oxygen to your tissues, give you energy. Your platelets, which clot your blood, prevent you from bleeding. And then the rest are really your white blood cells. And on the left here, we have your myeloid cells, the main ones of which are the neutrophil. They are the most numerous white blood cell, and they're very important for preventing bacterial infection. For those of you that have undergone any sort of chemotherapy, you may have received the growth factor, filgrastim. You might know it by brand names like Neulasta. And they're given during chemotherapy to boost your neutrophils to prevent any bacterial infections during therapy. Now, on the right side here is your adaptive immune system made up of the lymphoid cells, primarily the B cells, which produce antibodies to prevent infection. So if you get a vaccine, like the tetanus vaccine, the antibodies will be made by B cells. And then you have your T cells, which fight viruses, but also work to prevent cancer. We'll come back to how this is leveraged in CAR T-cell therapy. But it's important to know that T cells are what prevents everybody from having cancer. So the reason why people might be walking around cancer-free is that their T cells are going around surveilling all the cells in your body and eliminating cells that might turn into a problem. Now, if we talk about what lymphoma is, a lymphoma is a cancer of these lymphoid cells. And you can break lymphoma down into different categories: Hodgkin lymphoma versus non-Hodgkin lymphoma, T-cell lymphoma versus B-cell lymphoma. And for the purposes of what CAR T is approved for, those are all non-Hodgkin B-cell lymphomas at the moment. You can further subdivide these into either aggressive or indolent lymphomas. Aggressive lymphomas grow fast, can be life-threatening, but are curable in a proportion of patients. The primary example being diffuse large B-cell lymphoma. The indolent cancers are slow-growing. You don't usually have to treat them right away. You can wait until there's some concern for organ compromise or the like. But they are generally thought of as incurable. So treatment is something like whack-a-mole. You'll wait, treat the disease, have a period of remission, then the disease will come back again and eventually necessitate treatment. And the most common indolent lymphoma is follicular lymphoma. It's important to note that indolent lymphomas can transform into the aggressive lymphomas at the rate of about 1% per year, which is a cumulative risk. So if you have indolent lymphoma for 20 years, you're obviously at increased risk for transformation over time. And the one cancer that I also didn't mention in the lymphoma category is mantle cell lymphoma, which sort of straddles these two categories. It has features of both aggressive and indolent lymphomas, is generally considered incurable, but can certainly act very aggressively and require urgent treatment. Now, there are a fair bit of new treatments that have been approved for B-cell cancers in the recent years, and they, in large part, are leveraging the markers that are on the B-cell itself. So you can see here CD19, CD20, and CD79B are three B-cell surface markers that have been targeted by approved therapies for lymphomas. On the left, you can see there are different categories of these drugs. First, we have the antibodies, which are the oldest in these sort of targeted therapies, with rituximab being approved in the early 1990s. Essentially, an antibody labels the cancer for the immune system to come and clear it. Next, we have your antibody drug conjugates, which in theory provide targeted drug delivery. So the chemotherapy is supposed to be targeted just to the cancer, polatuzumab targeting CD79B and loncastuximab targeting CD19. And then the last of these being the bispecific antibodies, which is essentially two antibody arms stuck together, bringing the cancer and the T cells close to each other to allow the T cells to do their work. The examples that I listed here: glofitamab, epcoritamab, mosunetuzumab. I saw somebody on Twitter describe this as a Tinder for the immune system. So just to give you a sense of how you might think of bispecific antibodies. But a CAR T sort of operates, I'd say maybe a step above that in terms of its science behind it, in that it takes a T cell and actually modifies it to be able to kill cancer. So we talked about a little bit, a normal T cell interacts with tumor in a very restricted fashion to identify it and clear it. And evasion of this mechanism is one of the hallmarks of cancer formation. This is very tightly regulated because if you have unregulated T cells in your body, you might get something like autoimmune disease, for example. So what a CAR T does is it says, let's just put in a protein into the T cell that will allow us to interact with tumor without this restriction. And a CAR T has the additional benefits of being living cells, so they grow after you put them in the body. They localize to the tumor and carry out tumor killing, and then they can persist in the body to provide ongoing immune surveillance to prevent relapse. Now, why is it called a chimeric antigen receptor? So on the right is the figure from Greek mythology. A chimera is an animal with three different animal heads. So sort of like that, a CAR has different fragments from different parts of the immune system. So the targeting fragment on the outside of the CAR, outside of the cell, is a B-cell fragment that can bind to the target. And then on the inside are parts of the T-cell machinery, one being the co-stimulatory domain or the CAR motor, which we'll talk about in a bit, and then also the CD3 zeta part of the T-cell receptor, which functions as the kill switch after the CAR has engaged with the tumor. This is a nice diagram of the mechanism of action of CAR T cells. So first, viral DNA is inserted into the T cell, which can then lead to expression of the CAR on the T cell surface. After infusion into the body, the T cell will then be able to find the tumor via the CAR. After that, the CAR will multiply and release cytokines, which we'll come back to later, and through this process be able to kill the tumor. Now, this is a graphic of the U.S. approvals for CAR T-cell therapy in lymphoma starting in late 2017 in diffuse large B-cell lymphoma, going up to now into 2024, where we have multiple approvals in DLBCL, mantle cell lymphoma, as well as follicular lymphoma, and most recently, the first approval in CLL with liso-cel. Now, this is a list of the approved CARs in B-cell lymphoma. If you note, they're axi-cel, also called Yescarta, liso-cel or Breyanzi, tiso-sel, or Kymriah. You can see they all target the same target, CD19, and where they differ is really in their co-stimulatory molecule. So axi-cel uses CD28. This leads to fast CAR expansion, but peters out. So in less politically turbulent times, we refer to this as a Tesla, but now I think you probably have to pick a different fast CAR of your choice. And on the right, we have liso-cel and tiso-sel, which have a 4-1BB, which is a slower onset with longer persistence, which we can sometimes refer to as the Prius. You can see that axi-cel and liso-cel share similar approvals in all three lymphomas that we talked about, whereas Kymriah at the moment is primarily used in follicular lymphoma, really not as much in DLBCL. So the next question is, when might I actually be eligible for a CAR? And so the answer is follow the roadmap, which can be a little bit complicated, so we'll walk through it. Starting with diffuse large B-cell lymphoma, if you look at the top, patients get first-line chemoimmunotherapy, which is either R-CHOP are EPOC or POLA are chipped, and then about 60% of people are cured of their DLBCL. But for the other 40%, disease either never goes away, which is called refractory disease, or the patient will ultimately have relapse disease, meaning the disease went away and then came back. If the disease is refractory or relapses within 1 year, patients are eligible for CAR T. This has phase 3, so really the best evidence that we can have to suggest use of the therapy. 2 phase 3 trials suggest that CAR T is superior, so that is really the main way that patients will get CAR T in DLBCL. If you relapse after 1 year, it's a little bit murkier. If you're what we call transplant eligible, so autologous stem cell transplant, which used to be the hallmark of therapy for second-line DLBCL for about 30 years. If you are eligible for that, you could receive chemotherapy, and then depending on your response to chemotherapy, either get the transplant, or if the disease did not respond to chemotherapy, go to CAR T in the third line. And then there's also potential for patients who are what we call transplant ineligible to receive CAR T cells, liso-cel in this case, in the second line. Looking at follicular and mantle cell lymphoma, starting on the right with mantle cell lymphoma, and these, I would say, paradigms are pretty fast-moving as more and more drugs are approved in earlier lines of therapy. But at the moment, patients who are not on study for mantle cell lymphoma will receive chemoimmunotherapy in the first line, plus or minus a BTK inhibitor. So you might get chemo, you might also get an oral pill called a BTK inhibitor. And if you, and just to clarify, it used to be that we would give an autologous stem cell transplant to eligible patients in the first line for consolidation of mantle cell lymphoma. That we do not do anymore based on the Triangle study, which is a recent publication. So patients will not get an auto, but they'll get chemo plus or minus a BTK inhibitor. If you do get a BTK inhibitor in first line and then ultimately the mantle cell lymphoma grows again, you would then be eligible for CAR T in the second line. If you had never received a BTK inhibitor, you could receive a BTK inhibitor in second line and then CAR T in third line. So a little bit complicated, I think a lot of moving parts, but basically patients who are BTK exposed and then have progression of mantle cell lymphoma would be eligible for CAR T. In follicular lymphoma, CAR at the moment is pretty solidly placed in the third line, so patients would receive 2 prior lines of therapy before being eligible for CAR T. But I would also mention that for follicular lymphoma, we have many effective drugs, and the decision to go for CAR T versus a different therapy, I think, comes down a lot to patient choice. Do you want perhaps a one-time treatment and then have a treatment-free interval, or have more consistent treatment, whether you want to be in the hospital or not? Many factors that go into why someone might choose a CAR over a different therapy in the third line for follicular lymphoma, but there are many options at that time. Switching a little bit to the logistics of CAR T, and this diagram, I think of CAR T logistics as a 3-step approach. One, we have to take the T cells out of the patient. They are circulating around in your blood, so we have to get them from your veins. What we do is we put the patient on a machine that looks like a dialysis machine. Blood can be taken out of one arm, cycled through the machine. The T cells are taken off, and then the rest of your blood given back to you through the other arm. Sometimes the patients are not able to have this procedure through the peripheral veins. They may require a central line placed into a vein in the neck or in the groin. This is a one-day outpatient procedure. There really aren't many limitations after this procedure. And then the cells are sent to the company for manufacturing, which at the moment takes about 3 to 4 weeks. During that time, you may require what we call bridging chemotherapy for disease control. It really depends on the decision with you and your doctor about whether the disease is stable or whether you need some extra therapy. Then when the cells are ready, you will come back for first 3 days of outpatient chemotherapy with fludarabine and cyclophosphamide on day -4, 5, -4, -3. And then the patient could be admitted to the hospital for their CAR T infusion, but that really depends on which particular site you're getting your CAR T at. Some centers will let the patient start outpatient and then admit were there to be any toxicities, which we'll talk about in just a minute. But 3 days of outpatient chemo, then the cells will be admitted on day 0, and then a 28-day monitoring period. You can see on the slide that I've made two lines or graphs here. That is to show the differences in CAR T expansion. So you can see the axi-cel-like much higher peak and earlier, whereas the liso-cel-like has kind of a slower and steadier onset, but perhaps stays around longer than the axi-cel-like CARs. Now, what are the main early toxicities of CAR T? One is cytokine release syndrome. So if you remember from that graphic, once the CAR T will interact with the tumor, they will release these cytokines. Think of them sort of as hormones. They're not, but they function in many ways the same way. And I like to liken it to when patients have the flu. If you have the flu and you feel really bad, it's actually not the virus itself that's making you feel the way, but rather after the T cells interact with the flu, they're ramping up to get rid of it. And those chemicals that they release, those are the things that make you feel bad. So CRS is really that sort of experience, just more. So you might experience what we call the worst flu of your life. There are two primary effects. One is fever, the other is low blood pressure. Sometimes patients can also experience low oxygen levels in the blood. Most patients will experience a fever, so predominantly patients do get CRS. But what's really important is that our treatment of this has gotten much, much better, and the rate of severe CRS, where there are more complications requiring admission to ICU, for example, has become very low and is below 5%. The second early toxicity that I think may concern people more is neurologic toxicity. And I've tried to simplify the grading scheme here on the left. So grade 1 is just confusion. So we ask 10 basic questions to patients when they're in the hospital to ascertain whether they may be developing neurotoxicity. And so when patients are becoming confused, they may miss 1 or 2 of these questions, like what hospital they're in. Grade 2, we can see that the patients experience word-finding difficulties, so we ask them to say their name. They're not able to say their name. This is not a stroke, though it might look like one if you think about patients not being able to talk as a symptom of that. With CAR T, it's very much just an attention issue. The cytokines that we talked about can go to the brain and make it difficult to focus. Grade 3, so more severe toxicity, a patient can be hard to arouse. They may experience a seizure, or what I like to call lights on, nobody home, is the patient is awake and alert, but not able to track or really interact with the outside world. And grade 4 can be either coma or brain swelling. Now, the brain swelling, obviously a very feared complication, I would also say happens extremely rarely. Other things to know about neurotoxicity, the onset is after cytokine release syndrome. I'll show you a graphic of that shortly. The way that we think about it is typically short-lived. When it comes on, it might last about 3 or 4 days and then come off again. Classically, we talk about it as a very, very quick recovery. We do not think of this as a permanent situation in the overwhelming majority of patients. But I would say that in patients that are older or those that have mild cognitive impairment in the pre-CAR setting, they may have a more prolonged recovery. But I would say on the whole, almost every patient does have a complete recovery. Now, the rates of cytokine release syndrome and neurotoxicity are where we really see differences between the two types of CARs. So those CARs with that CD28 CAR motor have a little bit higher CRS, so 90% versus 75%. Again, rates of severe CRS very low for both types of products. Where they really differ is with the neurotoxicity. So with CD28 CARs, it's about 50 to 60%. Versus 10 to 30% with the 4-1BB CARs. And the rate of severe neurotoxicity is higher, about 25% versus 5 to 10%. There are lots of different trials ongoing to look at different strategies to reduce this neurotoxicity in the CD28 CARs to varying success. Now, as I mentioned, the onset of CRS and neurotox, so coming back to the graphic, the onset of CRS tends to happen between day 2 and day 5, and the neurologic toxicity tends to happen after that, somewhere between day 6 and day 10. So At my institution, patients are admitted to the hospital on day 0, and ultimately, because of this type of manifestation, if they develop CRS and then neurotox, they might stay admitted for about 2 weeks. If you're at an outpatient facility getting CAR, you might be admitted with your onset of CRS, so you may be able to stay out of the hospital for 2 to 3 days after infusion, then be admitted, then released after resolution of the neurologic toxicity. Turning to how we think about how a CAR works, so we want to talk about how is it effective. So there are different ways to think about that. One is response, which really looks at the tumor. So 2 different types of response. One is partial response, where the tumor shrinks by greater than 50%, versus complete response, where there's no detectable tumor on scan. On the left is an example of a patient of mine that had a partial response to therapy. Ultimately, the disease went on to progress. This is, I would say, more common than not. Patients that achieve a partial response only will end up having progressive disease. There's a proportion of patients, perhaps between 1/4 and 1/3, that may have ultimate resolution of the disease on the PET scan after achieving a partial response, but most patients with a PR will ultimately have the disease grow again. And on the right is a patient in CR. This patient is in an ongoing complete response, but not everybody that achieves a complete response will stay in a complete response. So while a PR and CR are important metrics, I think there are more important metrics to think about. From the patient perspective, patients want to know, how long will I be alive? How long will I be in remission? So the way that we think about that as oncologists, we rely on what we call Kaplan-Meier curves, which you can see in the graphic on the right, which we'll walk through. And they can look at the effectiveness of a treatment over time. So time is obviously a very important part of this. So 2 of the major metrics, one, perhaps the best metric, is overall survival. So this just measures, is the patient alive or dead? And the second, which we call a composite endpoint, is progression-free survival. So is the patient alive and in remission? Now, coming over to the curve, if we start at the top over here, 100% of patients are alive and they have not experienced an event, whichever event you're trying to measure. If it's overall survival, then the event is death. If it's PFS, it's death or relapse. And every time there's a step down, that signifies that a patient has experienced an event. So obviously, in a perfect world, the curve would be flat at the very top, meaning that 100% of people are alive in remission. But if there's a step down, it signifies a patient has experienced the event of interest. And then over here, at the end, we're looking for a flat line. So that is the percentage of patients that remain free of events. So the higher that flat line is, the better it is. It means your therapy is effective. Now, we do have an example of a curve in lymphoma with CAR-T. This is a PFS curve from one of the earliest trials in diffuse large B-cell lymphoma. And you can see at about 5 years, 30% of patients remain in remission. So that's what that flat curve shows. A proportion of patients that after 5 years following a single infusion of CAR-T remain in remission. So does that signify a cure? In DLBCL, some people would like to suggest that it does. And so this is an example of the potential of CAR-T. And the real question, I think, is does this also apply to those indolent diseases that we talked about, follicular lymphoma and mantle cell lymphoma? And on the left is a table. Again, it's a composite of many, many trials, so that's why it's a bit of a range. But if you focus on the progression-free survival for DLBCL, you can see about 30 to 40% of patients remain alive and in remission at 5 years. That number is higher in follicular lymphoma at about 50% at 5 years, and is a little bit lower in mantle cell lymphoma, so about 20 to 40%, depending on the trial you look at, with a little less follow-up, so 4 years worth of follow-up. And then looking at overall survival, whether the patient is alive. In DLBCL, it's about 50% at 5 years, higher in follicular again, 70% at 5 years, and in mantle cell lymphoma, about 35 to 50% at 4 years. So really, some of the things that we're going to be looking for going forward is really how does that curve flatten out, which we hope it does. patients might ask, what really mediates whether the CAR is going to work for me? And there are really lots of different factors that go into it, which we don't really have time to focus on, like T-cell health and things of that nature. But I think some of the most important things to think about are high tumor burden and inflammation within the patient. Both can impact CAR effectiveness. They're both interrelated, so perhaps high tumor burden can also drive high inflammation. But I think conceptually it makes sense. We put in a fixed dose of these CAR T cells, and you can think of them just running out of steam if they really have too much tumor to deal with. And similarly, in an inflammatory environment, there are lots of things that can actually sort of turn the CAR T cells off. So they go in kind of raring to go, and the inflammation sort of slows them down, weakens them, and ultimately mediates the disease progression. So this sort of takes us back to what I mentioned previously about the potential need for bridging therapy or therapy to reduce disease burden. If patients have large disease burden on the way to CAR T, they may benefit from additional therapy that we think could reduce disease burden before they get their CAR T. We talked a little bit about the early toxicities of CAR. I wanted to talk a little about the late toxicities. So one of which we've begun to note is second cancers. So patients getting lymphodepletion chemotherapy as well as CAR T cells can then have CAR T cell expansion, which mediates its own inflammation, as well as resulting in a weakened immune system for a period of time, which can lead to the outgrowth of second cancers, blood cancers, such as acute myeloid leukemia, as well as solid cancers. On the whole, I think blood cancers are more common and occur in about 5% of patients. I think that might be a little bit on the high end, but I wanted to bring that as the number when we have this conversation. I think that a lot of questions still revolve around this, whether that's mediated by a patient just being in later lines of therapy, so they've gotten lots of treatment already, which in and of itself, we know chemotherapy has an association with development of blood cancer. So if we move CAR T earlier on in the therapy paradigm, will that reduce this? Or is it really mediated in some part by that CAR T cell expansion and inflammation? And that really is an ongoing research question. And then we also have infection, which perhaps is one of the most important late toxicities after CAR T. You can see on the left a diagram talking about when patients are at high risk for infection within the first 28 days. Patients have also received chemotherapy, so their white blood cell count could be low, so they're at risk for infection from that perspective as well. But we also know that even going beyond day 28, patients can experience infection in an ongoing fashion. About half to three-quarters of patients will experience an infection in the first year after CAR, and that could be something as simple as an upper respiratory infection, but could be more severe as well, like a bacterial infection requiring IV antibiotics. And in some longer-term studies, we have noted that up to a quarter of patients that we were able to get information from did have severe infections requiring something like hospitalization or IV antibiotics. And that can result in something called non-relapse mortality. Non-relapse mortality is when a patient dies of something different than their lymphoma. So to put that in perspective, we actually want all patients to not die of their lymphoma. So in theory, we're looking for 100% non-relapse mortality, patients growing old and dying of something else. But this is not what we're talking about. We're talking about non-relapse mortality early after CAR while the patient's in remission. And what you can see from the graphic on the right is from perhaps the largest study looking at these events. About half of those in total are driven by infection. So this is a very important facet of CAR therapy that we're trying to work on to reduce the risk of NRM the further out people get from CAR T therapy. Lastly, what if a patient were to relapse after CAR T? And this is a little bit dependent on the fast-moving paradigm where different therapies are moving earlier on in therapy, so this may change quickly. But right now, if you are not a bispecific exposed and ultimately have relapse after CAR T, that would really be the next best therapy. You can see in DLBCL, I listed a number of bispecific glofitamab, epcoritamab, mantle cell lymphoma glofitamab, follicular glofitamab, and mosunetuzumab. And then there are other options, which I've listed here. But I think it's also important to put a plug for clinical trials. I think if patients get into third and fourth line of their therapy, that is certainly a time to consider clinical trials with novel agents. So in summary, what we talked about today is CAR T has gained approval in both aggressive and indolent lymphomas. The 5-year follow-up shows that a proportion of patients do have durable remissions, which I do think is suggestive of a potential cure. CAR T remains an involved logistical process both before and after treatment, so a good support system is really important to make this process smooth both for patients and their caregivers. The longer-term toxicities are increasingly recognized in an active area of research to be able to allow patients to enjoy remissions induced by CAR T. And lastly, the treatment paradigm in lymphoma is changing rapidly, and when CAR T is used may be different in the coming years, but as a very powerful modality, CAR T will likely remain a mainstay of treatment for the foreseeable future. And with that, I'd like to thank you for your attention. I'll be happy to take any questions.
Thank you, Dr. Spiegel, for this excellent presentation. We'll now begin with some questions. And as a reminder, if you have a question, type it into the chat box on the left, and we will get to as many of them as possible. So let's start with the first one. A listener would like to know, how long do CAR T cells keep doing their thing?
That's a great question. So there is some data for the 4-1BB CARs, that is the slower onset CARs, the Prius, if you will. In some people, they can stay in the body for years. So there's data from the earliest patients treated at the NIH and at Penn, where they looked and they found that actually 10 years later, they found patients with circulating CAR T. I don't think that's true in most people. I think for those Prius-based CARs, it will be a number of months. In a different treatment paradigm, acute lymphoblastic leukemia, they actually monitor whether a patient will have their B cells suppressed. So not only do CAR Ts kill the cancerous B cells, but they also kill normal B cells. So in acute lymphoblastic leukemia, doctors actually monitor B cells, what we call B cell aplasia. If there are no B cells, we assume the CAR Ts are still doing their thing. If the B cells come back, we assume that they're not. And in ALL, that is a concern for relapse. In lymphoma, that's not quite the same story. We see B cell aplasia last maybe 6 to 12 months, and then the B cells can come back, but that does not actually mediate relapse in a lot of patients. So I would say on the whole, for most people, several months, some patients a little longer. But even if those B cells come back, which suggests that the CAR Ts aren't actively doing their thing, does not mean that relapse is guaranteed.
All right, thank you. And this gentleman wants to know specifically about axi-cel. Are there any studies on this, how long it works?
Yeah, so for axi-cel, it's detectable in the blood by flow cytometry or by PCR, which is a little bit more at the genetic level, probably 1 to 2 months. There are some interesting data looking at different methods of measuring these CARs, so cell-free DNA, where we know that cells can actually secrete their DNA into the blood as they die. And that might give you a measure of whether CAR T cells are actually hiding in the tissues and not detectable in the blood. And there are some studies that suggest that CAR T may actually be hiding around in the blood, even if we can't detect, maybe hiding in the tissue, even if we can't detect it in the blood. But I would say that that's still really experimental. So I'd say from what we know in the blood, 1 to 2 months, but perhaps they are hiding out in the tissues and we just can't find them.
All right. Next question. Are people immunocompromised after CAR T, and for how long?
Yes, that's a great question. Very important question. So people are immunocompromised after CAR T. How long? I would say depends. So the way that we monitor that is by looking at patients' B cells and also their T cells. So after you get chemotherapy and CAR T, your T cells will not return to normal probably for more than a year. So your adaptive immune system is not functioning at its best. B cells, as we mentioned already, 6 months to a year, sometimes people even more. So we do keep people on two medicines. One is acyclovir to prevent shingles, and the other is Bactrim to prevent and pneumonia that can occur in patients who are immunocompromised. And what I do at our center is keep patients on that until their CD4 count is greater than 200. So if that's at plus getting to a year after therapy. So if it's the CD4 count recovers and they hit a year, I'll take them off. If they're at 1 year and their CD4 count's still less than 200, I will keep the patients on Bactrim and acyclovir.
All right, the next question is, I have diffuse large B-cell HNL. I had a stem cell transplant in CAR-T last April. Recent PET scans showed suspicious lymph nodes in my neck and armpit. Excision biopsies revealed no abnormal cells. Why are we getting false positive? Can we prevent that in some way?
That's a great question. So I think that that is a phenomenon after CAR-T, but I would say, so certainly we know that patients can have abnormal PET scan findings after CAR-T that are benign. I think that it's also important to note that PET scans do have a false positive rate in all lymphomas. So the thing about a PET scan is that it is sensitive but not specific. So when something lights up on a PET scan, it could be a problem, but it might not be. So for example, if a patient has had a recent infection, they might have swollen lymph nodes. Like if you get a sore throat, you might feel that your lymph nodes in your upper neck are a little bit swollen. If I took you and gave you a PET scan while you were actively sick from that, your neck nodes might light up. So PET scans have a false positive rate anyway. Now, there are different modalities that people are working on. So, for example, there is a test called clonoSEQ, which looks for the genetic blueprint of the lymphoma. So every B cell has its own B cell receptor, which is unique to it. And we know that every B cell cancer began initially from one B cell. So we can find the genetic blueprint for that B cell receptor, which we would associate with the cancer. We could find that in a patient's blood. And that has been approved for monitoring in DLBCL and in mantle cell lymphoma. Now, for patients such as yourself, you could, in theory, do that test as a second way to look for the cancer. But that also has problems. I think, the tests are only as good as they can be. And there will always be some false positives and false negatives associated with them.
All right, well, that's good to know, very clear. The next person wants to know, is CAR-T cell therapy still an option in mantle cell lymphoma if you already had CAR-NK therapy in a clinical trial?
So that's a good question. So there's the insurance answer for that, and then there's the scientific answer for that. So I would say the insurance question is they may try to deny it on the basis of you having received the therapy before. That said, from the scientific perspective, it depends on what the CAR-NK targeted. If the CAR-NK targeted CD19, I would suggest retesting for presence of CD19. We know that one reason that CAR-Ts don't work is that the lymphomas are smart and they manage to downregulate CD19, so it's not on the surface anymore. So if there's no target, the CAR-T won't be able to find it. Now, that happens much more in ALL than in lymphoma. Lymphoma, maybe it's a quarter of the time, 30% of the time. So I think what I would say is that if the CAR-NK targeted CD19, but you still have CD19 present on your cells, I think you should still be able to get CAR-T and get a remission. But then you unfortunately, we have to deal with the other part of that, which may require a little bit of work on behalf of your treatment team.
All right. All right. The next question. If a person is taking medication to keep depression and anxiety under control, will it affect the risk for CAR-T side effects?
No. No, it does not. We don't have evidence that SSRIs or medications like that affect the rate of neurotoxicity. I would say
Great.
that even patients, with seizure disorders, technically were excluded from the initial studies, but patients that are stable on anti-epileptic medications, we still have taken to CAR T, and we do not see really an increase in toxicity.
Great. That's good to know. This person wants to know what exactly is a caregiver expected to do while caring for a CAR T patient? Why is one needed 24/7, and for how long are they needed?
Yeah, that's a great question. So needed is always, so the way these things were developed is they were developed 8 years ago, and perhaps, the FDA requirements around them haven't evolved necessarily. So when a patient is in the hospital, a caregiver certainly is great to help the patient, advocate for the patient in dealing with the medical staff. But in terms of absolute necessity, if you have to be at work and you only can visit your loved one every so often, certainly the medical team is going to be able to take care of them. When you go home, it depends. If the patient has experienced some toxicity, they may be weak, they may have some difficulty eating, so they might need help with that. They might need help, with mobility, depending on how mobile they are when they leave. If they've had steroids in the hospital, they may be a little bit weak when they get home. The requirement for 24/7, I think, is really directed around the concern for neurologic toxicity, which, does require urgent treatment. I think that, in truth, the late onset of neurotoxicity is very rare. So I would say if you get beyond day 14, but certainly beyond day, 18 or 20, the rate of new onset or even recurrent neurologic toxicity is very rare. So from the absolute perspective, I think the risk is very low, but it is there for if a patient develops neurologic toxicity.
All right. The next person wants to know if you have DCBL in the CNS, is CAR T effective?
That's a great question. So now it depends a little bit. If you have primary CNS lymphoma, that is, if the lymphoma was only ever in the brain and never anywhere systemically, CAR T is not approved. There have been some studies ongoing for CAR in that situation, but it is not part of the commercial approval for CAR T. Secondary CNS involvement, meaning that patients have lymphoma elsewhere and then it goes to the brain. Patients can receive CAR T on the commercial label. It doesn't exclude them. They were excluded from the initial trials, though. I would say on the whole, it is less effective. And perhaps if we're talking about durable remissions, it's somewhere in the 20 to 25% versus the 40%-ish that we were talking about before for DLBCL.
Okay, great answer. Next question, is there an age limit for CAR T-cell therapy?
I would say no. I think that, for example, liso-cel was specifically studied for older patients. The trial is called the pilot trial. So one of the criteria that they used for transplant eligible was age. I have treated patients in their late 80s, and I know there have been centers that treat patients in their 90s. I think the question really is a matter of discussing with the patient about potential quality of life concerns. So certainly, CAR T is an involved process, may involve a hospitalization, lots of doctor's visits. So I think it's important to go over that with the patient. But I don't think that there is necessarily an age limit a priori for CAR T.
All right. This woman has had CAR T-cell therapy, and she said, I had to learn how to walk without help and how to swallow again, among other challenges. Is this common?
I would say no, but it depends. So everything is qualified. So what I would say is that patients can experience significant neurotoxicity. We talked about that even in the more quote unquote gentle CAR Ts, the Form BB, can be up to 10% of patients experiencing severe toxicity. So if a patient experienced grade 4 toxicity and they needed to be on a breathing machine, for example, a lot of the things you're describing are part and parcel of being on a ventilator. If you get intubated and then you come off the breathing machine, you may need to learn to walk again. You may need to learn how to swallow again. Patients that require loss of steroids to control their neurologic toxicity, particularly if they're older, can experience weakness. Steroids can cause weakness. And then also just, a patient remaining in bed for a long period of time can have weakness. So I would say physical weakness can be more common after CAR T if you experience toxicity because of A, the steroids, and B, sort of like getting your sea legs back. If you're in bed for a week and then you get up, you may have significant weakness because you haven't been out of bed. So I would say there is definitely a proportion of patients that experience physical weakness. We have had to send patients to rehab after CAR T if they experience toxicity. I do think anecdotally that is getting a little bit less. We are getting a bit better at preventing those, but the truth is that still does happen.
All right. The next question is, how long does it take for blood counts to recover after CAR T?
That is a great question. So again, it depends. There is I would say on the whole, patients will recover their blood counts within 2 to 3 months. So the main thing that is affected blood count-wise after CAR T is the white blood cell counts. About 1/4 of patients will require transfusion in the course of CAR T, but the hemoglobin and platelets do recover pretty quickly. White blood cells, on the whole, probably recover about 2 to 3 months out. But when we've looked later, we've had about 10% of patients with ongoing low white blood counts, even a year post-CAR therapy. A lot of that is mediated by what your blood counts are on the way in. So there's a very interesting group of papers from a group from Germany led by Kymriah, and they have a calculator called the CAR Hematotox, which you can access online, and that will help calculate your risk for low blood counts after CAR T. If you're interested before the CAR T process, I would certainly ask your team to calculate that for you because it can give you a sense of what your particular risk might be.
Interesting. Next question, do you need to be revaccinated after CAR T like you do after a transplant?
Another great question. So it depends. So what we have started doing is we will, after a year, we will check the titers of the antibodies for various conditions that are vaccinatable. So if a patient has adequate protection, we will not revaccinate them. If they don't have protection, then we will give them that vaccine. So you can have patients that have protection against nothing, and we'll have to revaccinate them for lots of stuff, or they could actually be protected against everything, and we won't vaccinate them. You might get Shingrix again because that's more of a booster to prevent shingles, but if you have protection against measles, you don't need another MMR shot. If you have protection against pneumonia, you don't need a pneumonia shot. So we do it based on titers. There is a paper from the group at Fred Hutch in Washington where they looked at this, and they found that lots of patients with lymphoma actually do maintain their protection against these diseases. So they retain their vaccination status even after CAR T.
Oh, that's great to know. This is a question about long-term follow-up care. If a patient has to travel to go to their CAR T center, do they need to go back to visit periodically for follow-up care, or is that all handled locally by their local doctor?
I think that also depends on the relationship with the center. So there are certainly centers that are internationally renowned, and patients will come internationally, and then they're not going to come back again. So certainly it can be done. I like to see patients because I think that, CAR is still relatively niche as much as I love it. And it's what I do for a living. It is niche, and I think that there are things that come with that do require some extended care. But I would say that can be intermittent, and you could also, if your home physician has a good relationship with the treating center, they can communicate and they can manage you at a distance. I do think it's not a bad idea to go periodically, but I think, is it necessary? I think it can be done if there's close collaboration between the treating center and the home physician.
All right, the next question is, we have stem cells left after an autologous transplant. Would these be helpful to boost the immune system either before or after the CAR T procedure?
Another fantastic question. So the answer is it could be useful if a patient has persistent low blood counts. Stem cells could be helpful to boost that later. So that is currently more commonly used in multiple myeloma post-CAR, where there are more significant low blood counts. Patients are using bank stem cells as a stem cell boost. In lymphoma, I would say we tend not to have to use it, but it could be useful if necessary.
All right, the next question is, can you share the paper about post-CAR T vaccination? For example, can you send it to BMT Infonet, and then we can send it out to the people on the call? Okay, great.
Absolutely.
So we'll take care of that later today or tomorrow. And then the final question is, can you comment on any clinical trials or research that's ongoing to expand the use of CAR T cells to other types of lymphoma?
Yeah, so there have been a variety of clinical trials in other types of lymphoma. Those tend to be rare lymphomas, so they're harder to get numbers for patients. I would say for something like Burkitt lymphoma, which is very aggressive, there hasn't been the same degree of success. And with some of the other indolent lymphomas, I think it's been very hard to get data. So there are some clinical trials with Waldenstrom's that have been a bit promising, so lymphoplasmacytic lymphoma. Burkitt, I would say, on the whole, hasn't been terribly successful. Hodgkin lymphoma, there were some earlier promising studies, but I would say it's not particularly close to being approved. So, and T-cell lymphomas, which is really a huge area of need for a variety of reasons, this approach is quite difficult because the cancer is in the T-cells, so you run the risk of actually putting a CAR into the cancer. You also run the risk of the CARs killing themselves, which we call fratricide. So there are lots of novel approaches to trying to make CAR T viable in T-cell lymphoma, but I would say we're not quite there yet.
All right, and with that, I think we'll have to wrap up the session. I want to thank Dr. Spiegel for this excellent presentation. And I also want to thank the audience who offered some very good questions. If you have any needs, and please contact BMT Infonet at the number on the screen or the email on the screen, and we'll be happy to reach out to you. Enjoy the rest of the symposium and enjoy the rest of your day. Thank you.